Hi, everyone, and welcome to this panel session that you're seeing from the Winter Hematology Update 2021. This is just after a presentation on COVID-19 vaccines in oncology patients, and we have the opportunity in the next 20 minutes or so to cover one of the hot button topics for all of us in the field at this point. How will we be managing our patients during this pandemic? So once again, I'm John Curvilla. I work at the Princess Margaret Cancer Centre here in Toronto.
I'm Peter Anglin. I work in Newmarket at the Stronach Cancer Centre.
And I'm Coleman Rothstein, infectious diseases physician, somewhat different than the hematologist oncologists on this panel. And I work at the University Health Network of the University of Toronto.
Yeah, and so you've just seen the great presentation that Coleman gave, which I think was a great overview in terms of highlighting some of the data around outcomes in patients, as well as the available data looking at the vaccines that are in development or now available in Canada, and some of the rationale behind some of the recommendations that people are trying to make about the management of oncology patients in this setting. And so with that as a background, maybe I'll just start by saying, Coleman, in terms of being on the ground, what are your thoughts about how the rollout is going for the vaccine? And how do you think, I know it's tough to really comment on what the government may do in terms of prioritizing how the vaccine rolls out, but what do you think might be an approach that will come in the province and how that may affect our patients?
I think that's a very interesting question, John, because currently there's a hue and cry because of our dearth of vaccines. And I have to explain to you why we have that problem. So unfortunately for us, the government had only decided to get about 10 million doses of the Pfizer vaccine. The Moderna vaccine, they were supposed to get more than that, approximately 40 million doses. Now, they put all their eggs in the wrong basket, I feel, because they made agreements with other companies expecting those vaccines to roll out, and they haven't. They haven't been licensed yet. So currently, the AstraZeneca vaccine is being considered by Health Canada. That's what I mentioned. And it should be approved in the next week or so, but there will be caveats to that. The caveat to that is it's only going to be approved for people between the ages of 18 to 64. Those over 65, so 65 and greater, unfortunately, don't respond to that vaccine very well. Now, there is a problem in our hematology oncology patients because of immunosuppression. We may expect that they will not respond as well. Their response will be blunted, and that creates additional problems. So I would say, in summary, the rollout has been slow. We've been hampered by the acquisition of vaccines, and that is because we just don't have agreements in place with Pfizer, Moderna, and also AstraZeneca. We're only basically contracted with them for 10 million doses. So you can see that we have a deficiency of vaccines. Hopefully, as other vaccines come online, and I mentioned Novavax will probably come online in the second quarter of 2021, and then we should be good to go.
Coleman, you showed us in your talk a plethora of vaccines in the pipeline coming. And you showed us nicely the Moderna, the Pfizer vaccines, the mRNA technology. Are there any vaccines that are concerning for patients who are immunocompromised in terms of live attenuated, or are all of these killed vaccines?
Thanks for that question, Peter. It's a very good question. None of the vaccines that we're using are live vaccines. Even the inactivated ones that are produced in China and India are not live. So basically, they've taken the virus and inactivated the virus. The other vaccines are derivations. They're subunits. So sometimes we'll take the spike protein and create recombinant technology around the spike protein and combine that with an adjuvant. That's fine. The messenger RNA vaccine, we take nucleotides, that is the DNA, the genetic markers, I should say, of the spike protein and incorporate that in the messenger RNA. Messenger RNA is cleared from the body in days to weeks, and just a spike protein is produced within the body. So I'm not really concerned about that. However, I will mention to you that there is one bit of noise that we should be cognizant of, and that is with the vector vaccine, that is the adenovirus vector vaccines, the human body can actually produce a reaction to the vector itself. And that may pose some problems in the future. I just don't know about that yet. We haven't seen anything, a significant signal about that, but I'm letting you know that it's a possibility.
Yeah, and so maybe to pick up on that theme a little, Coleman, in terms of safety. Now, as you highlighted in your presentation, the studies were done largely in healthy populations, and so the safety data there looked, I think, quite reassuring in general. Would you think that there would be any reason to expect anything differently from a side effect standpoint from the vaccines? And for our patients, let's say this may be happening during or soon after chemotherapy, based on the timing of these reactions, we've had lots of experience with seasonal flu vaccines, et cetera. Is there anything that the clinicians need to think a bit about around timing or low-grade fever or when to worry?
Unfortunately, John, we just don't have the data at our disposal right now. I think we're accumulating data from the UK because they've immunized a lot of people there. And so far, using the AstraZeneca vaccine and the Pfizer vaccine there have not been any major signals about what you're talking about, safety concerns in the oncology patient population. But one must recognize that our patients are quite immunosuppressed, and something may arise in the future. Maybe not now, but later on. We just have to be aware of it and watch closely.
And to take John's point, I think the message that we're getting is the majority of cancer patients should be vaccinated. There are some caveats there, to be clear, in terms of post-transplant. The CTLA-4 ipilimumab type drugs where there may be some hypersensitivity, but we're hearing most patients should be vaccinated, and that's a discussion most of us are having with our patients. When they get access to that, it's a separate issue. But I guess to that point, what does a blunted response really mean? I hear that all the time, and neutralizing antibody activity and blunted response. What does that mean? Is it for a non-infectious?
It's a real thing. I'll tell you, it's a real thing. So let me give you an example. We know that in solid organ transplants, from the data we've received in a preliminary fashion from the US, for example, kidney transplants who are on triple immunosuppressive therapy with things such as myfortic, prednisone, and a calcineurin inhibitor, only about 43% of those people will respond to the Pfizer vaccine. Now, we heard that in the general population, we're going to see vaccine efficacy in the range of 90 and above %. Now, it may be far less. So when I say the response, I'm talking about the antibody response. Now, you can imagine in our situation that we give rituximab to a patient, are we really going to see an antibody response when a patient is on rituximab? I have grave concerns about that. I think it will really be blunted.
And just to follow up that, Coleman, are you aware of correlations between lymphocyte counts, lymphopenia, and responses? Because the rituximab is one of the most relevant issues, I think, for the hematologic population in terms of widespread use. There's a lot of people out there on rituximab for different regimens, and they're lymphopenic for a period of time after the regimen. Is there a correlation between lymphopenia and the degree of lymphopenia and the antibody response? Are you aware of any published data on that?
No, Peter, I'm not aware of any published data, but we have to be concerned about that. That's why in my talk, I said, if you're giving dexamethasone, think about it, because you're going to get lymphocytopenia for a period of time after dexamethasone. So perhaps you should delay initiation of the vaccine series till you see a bit of a rise in your lymphocyte count.
Thanks.
And I guess, again, a little bit of a follow-up to that, Coleman. So when we're thinking about, the patient that we're initiating therapy, and if we fast forward a couple of months and vaccine may be available, um, do you think there's a rationale, accepting if we need 2 doses for the vaccines, to have the first one given potentially if you do have a window before starting curative therapy, and you may not be able to really delay a meaningful period of time, but is there a rationale to try to get at least a dose of vaccine before treatment commences, or do you have a sense it may not matter?
No, I think that's a very good point, John. And I would say yes, we should. That's why in my talk I said try to give at least the first dose 2 weeks before administration of any chemotherapy. Now, with the vaccines, we know we can delay the second dose, and the second dose really tops you up. I showed that after the first dose, beyond 14 days after the first dose, we start to get an immunoglobulin response, and you're in the 90% vaccine efficacy range in the normal population. Immunosuppressed patients, it may be less, but you're right up there, hopefully. So yes, you can delay the second dose, and there has been some modeling done where they've delayed the second dose of Moderna over a period of time, up to 12 weeks, and the response that you get, vaccine efficacy, is still excellent and is maintained for that length of time. If I could add one caveat, though, to everything I've talked about, is the durability of the antibody response. That's of concern to me in someone who's immunosuppressed in an oncology patient. We know some data about durability in the normal population. I have no idea what's going to happen in the immunosuppressed population.
Do you think any neutralizing antibody titer or test will be available widespread going forward, Coleman? Or do you see a role for that?
Well, I'm not sure. That's another important question, Peter. I'm not sure if I see a role for that, because the antibody titer doesn't always respond to your protection. There are 2 arms of the immune system that we have. We have adaptive immunity, that's the antibody response, and then we also have innate immunity. So let's say your adaptive immunity doesn't kick in properly the way you'd expect it to. Our innate immunity, however, can pick up, and the innate immunity lags behind the adaptive immunity. So it's possible you could have good memory cells through innate immunity that will protect you for a more prolonged period of time. We don't know that yet.
Thank you.
And I guess maybe one more practical question, if I may, Coleman. So, in the short term, as we're, dealing in a window where we don't have patients vaccinated, we'll still continue the approach that in the right clinical situation, someone comes in, you're suspicious about COVID based on symptoms, or you're doing a swab before someone starts therapy to look for disease, you'll swab them. Now, in the patient that may be vaccinated, just because, again, we don't know the operating characteristics, if that patient presents with upper respiratory symptoms, presumably we just go with our standard. You swab them, you do the appropriate workup, you assume that you don't know that they have protection.
Yeah, you don't know, but the hope is, if I could add a slight variation on the theme.
Sure.
We know that some people who get the vaccine do develop asymptomatic COVID infection within their nasopharynx. The Moderna vaccine reduces that number considerably. The AstraZeneca vaccine is somewhat efficacious there, but not totally efficacious. So you still can get asymptomatic carriage of COVID. Now, what you said is, suppose someone got the vaccine, you're not sure how they've responded, and you do a swab and they're COVID positive. Well, I would hope that the viral load in that sort of situation is quite low. And this has been looked at by something called the cycle threshold. So if the cycle threshold, if you do a swab and it's positive, and the cycle threshold is greater than 24, very low chance that this is going to create a recrudescence of infection or anything like that. However, if the cycle threshold is greater than less than 24, there may be a chance that the person could become infected again. So this is something which is coming to the fore now, and people are talking more about the cycle threshold. This may pose a problem. Let's say you want to give someone chemotherapy, they've had COVID, and they're COVID positive. Are you going to give them chemotherapy? Well, no, you're going to, no, I'm not. But maybe you can give chemotherapy if the cycle threshold is high, showing a low load of organism, less chance of recrudescence or infectivity. You may still be able to do this because it has been demonstrated in some lymphoma patients that they've been COVID positive for months. And
And
that
so
would
does,
really delay their chemotherapy.
and so, sorry, Coleman, just in order to answer the question around the cycle threshold, do you need 2 time points to assess, or it's just,
No,
it's
just
a
one.
one sample test that you can, cool.
Correct.
Okay.
And the lab has this. Every lab has this information because it's all a PCR test.
And I guess, maybe that leads into another question just from a practical standpoint. On the testing side, at least, I guess you can speak hopefully for Toronto and maybe a little bit for Ontario. Like from a capacity standpoint, are we in a decent spot in terms of the ability to get tests for our patients without a lot of delay? Or do you see the potential that we need to be concerned again about getting tests back in a timely manner?
No, I think in Ontario, this is improved tremendously. The government has done a very good job in rolling out more testing. And I think now people can book their tests and get the tests done within a day. I think it's much, much better than before. Much, much better.
Maybe one more thing, if I may, Coleman. So maybe on the speculative side of things, as you touch base on this a little in your presentation. So how the variants may play into this now and what we may see over the next few months. What do you think that means for the clinician on the ground in terms of how we operate? Does that mean we need to think differently? Do we need to alter testing strategy? Where are we?
Well, my hope is to get more people immunized. Now, once they're immunized, we know that the vaccines are pretty good against the UK variant. That's a B117. Against the South African B1351, they're not quite as good, but they're still good. Now, I don't know anything at this point about the P1 variant. That's a Brazil variant. So I think you just have to be cognizant of this. If someone's been immunized and has symptoms of COVID, got to think about the variant, But my hope is that as time rolls on, what the companies are going to do is they're going to create boosters that will include nucleotides and messenger RNA vaccine that will code for these variants. And I hope in the future we'll be up to speed with all the variants.
Any other questions, Peter?
That was a great review, Coleman. Thank you very much. Very helpful.
My pleasure. Thanks, Peter. Thanks, John.
Yeah, and once again, I'd like to thank the audience for being able to spend this time with us on this obviously challenging topic. And it's been remarkable to see, much like we've been talking about in the field of hematology and oncology, how quickly the pace of innovation has been to really see how quickly the vaccines have been developed, how quickly we're now seeing therapeutics potentially developed as well. And even though it's obviously been a hugely difficult and challenging time for people, medical science has really made a big impact here, which is, again, one of the reasons we're able to bring these types of meetings to you to highlight these findings. So thank you.
Thank you.